Welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Dawn Liz Powell, Medical Editor at MIMS Learning, and here with me is my colleague Rhiannon Ashman, Deputy Editor at MIMS Learning.
Hi Dawn.
Okay, Rhiannon, big sharing moment for you. Several years ago, I went to the doctor because I thought I was depressed. I felt utterly miserable. I couldn't take pleasure in anything. I was so unhappy that at times moving felt physically painful. However, the doctor said I wasn't depressed. Why do you think that was? And to give you a clue, I don't think this doctor was being dismissive. In fact, I think they were being very kind.
That sounds like you were having a really difficult time, Dawn, and I'm sorry to hear about that. And I wonder if this was the first time that you'd felt that way, perhaps something else was going on in your life at the time.
Yeah, in fact, my mum had died a couple of months beforehand, so I wasn't depressed, I was grieving. My sadness was a very normal response to a major life event. Though, as an aside, grief is personal and how you deal with it is individual, so if you're going through a grief, you might not feel that sadness. Anyway, the point is that sadness can be a normal part of life and not a sign of depression. Today, in this episode of the Clinical Update Podcast, we will be looking at the diagnosis and management of depression. And one of the things we will be looking at is how to distinguish depression from normal sadness.
Absolutely, and I'm sure we can all relate to feelings of low mood to a greater or lesser degree. And we do have a case study on this on MIMS Learning by our mental health clinical advisor, Professor Carolyn Chew-Graham. So Professor Chew-Graham says that because of a historic drive to increase identification of depression in primary care, there are now concerns that, quote unquote, misery is being medicalised. That is, that normal feelings of unhappiness are being diagnosed as depression and antidepressants are being prescribed to treat it. She observes that the available evidence suggests that antidepressants are only effective for people with severe depression.
Okay, so not everyone who presents their GP with low mood will be clinically depressed. Let's have a look at what NICE says about distress versus depression. In its guideline on depression in adults, NICE doesn't refer to distress, but does refer to less severe depression and more severe depression. It states that depression severity exists along a continuum and is essentially composed of three elements: symptoms, duration of the disorder, and the impact on personal and social functioning. The severity of depression is therefore a consequence of the contribution of all of these elements. Additionally, in her module on the guideline, GP Dr. Tony Hazel observes that NICE now has a more holistic view of depression compared with what it had in previous guidelines. While it does refer to symptoms, NICE says other factors should be taken into account, such as lifestyle, past traumatic life events, and current living conditions and employment status.
So to take the first of those three elements that you mentioned, Dawn, let's go over the symptoms of depression. The DSM-5 lists symptoms including depressed mood most of the day, fatigue or loss of energy, feelings of worthlessness or excessive or inappropriate guilt, and markedly diminished interest or pleasure in all or almost all activities most of the day. Now, although these symptoms can fluctuate, the symptoms should be present nearly every day, and they should not directly be caused by the physiological effects of substance abuse or a physical condition.
Of course, many illnesses can contribute to depression, for example, chronic pain. In the learning module we have on this topic, Dr. Mick Sapel says there is a strong correlation between pain and depression. This is a bidirectional relationship which can be a vicious circle which they feed off and amplify each other. Increased pain can worsen mental health, and increased psychological distress can worsen pain. The module gives advice on useful interventions, so it's worth a closer look.
And to return to the experience that you shared earlier, Dawn, about your bereavement, previous versions of the DSM, interestingly, included what was known as a bereavement exclusion, which meant that symptoms occurring immediately after the death of a loved one effectively didn't count towards a diagnosis of major depression unless they were severe or lasted for longer than 2 months. And the intention of this was not to medicalise grief. However, this exclusion was removed from the latest version, the DSM-5, which was somewhat controversial, but the reasoning was that although bereavement-related grief and major depression share some features, they are distinct and distinguishable conditions, and bereavement doesn't immunise a patient against experiencing a major depressive episode. And in fact, of course, bereavement is a common contributory factor, along with many other significant life events, as we touched on earlier. So diagnosing depression in this context takes some careful clinical judgment. And with reference to the second and third of the elements that you mentioned, NICE says that clinicians should consider using a validated measure such as the Patient Health Questionnaire 9 or the PHQ-9 to help determine the duration of symptoms and the effect that they're having on a person's life. Now, in the case study by Professor Chu Graham, the patient has a PHQ-9 score of 8, which Professor Chu Graham observes indicates that she does not have severe depression. A score of 5 to 9 suggests mild depression, or what NICE now calls less severe depression. A score of 10 to 14 indicates moderate depression, and a score of 15 or more indicates moderately severe or severe depression.
Yeah, and importantly, whether someone is categorised as being distressed, mildly depressed, or as having less severe depression, NICE does not recommend routinely using antidepressants as first-line therapies for these patients unless the patient has a clear preference for them. Instead, the management options include guided self-help, CBT, and group therapy. However, Dr. Hazel observes in her module on the guidelines that the waiting times for NHS psychological therapies can be long. Also, while there is evidence for St John's wort in this area, clinicians should not advise its use or prescribe it because of uncertainties about the appropriate dose and persistence of effect. If patients say that they want to try it, clinicians should advise them about the different potencies of the preparations available and of the potential serious interactions with other drugs.
Right, so antidepressants should not be routinely used for people with less severe forms of depression, but they do have a role for people with more severe forms of depression. And for this group, both antidepressants and non-pharmacological options can be used first line. So pharmacological options would include SSRIs or SNRIs, and choice of treatment depends on the patient's feelings about specific medication effects such as sedation, concomitant illness or medications, suicide risk, and previous history of response to antidepressant medicines. NICE says that the benefits of antidepressants should be felt within 4 weeks, and patients prescribed antidepressants should be reviewed regularly.
Yeah, and that reminds me of a news story I saw a couple of years ago. The BBC reported that more than a quarter of patients on antidepressants in England had been taking them for at least 5 years. This is a concerning statistic because the evidence for the long-term use of antidepressants is limited. Additionally, in her module on deprescribing antidepressants, Professor Chu Graham reports that up to 50% of people on antidepressants no longer have an indication for them. Whether this is because they didn't have severe depression to begin with or because their severe depression has resolved is not clear. She adds that coming off antidepressants is often difficult because of fears of relapse, withdrawal symptoms, and a lack of psychological treatments to replace maintenance treatment and prevent relapse.
On the topic of withdrawal symptoms, though, a systematic review published in JAMA Psychiatry last month, in July 2025, found that while people who stopped taking antidepressants did have more symptoms, such as dizziness, than those who continued to take them, many did not reach the threshold to be considered to have clinically significant withdrawal syndrome, and relapse was not associated with withdrawal of antidepressants.
I think it's important to note that withdrawal can still occur and how the antidepressants are withdrawn may make a difference. In the study that you've just mentioned, abrupt withdrawal resulted in significant discontinuation symptoms compared with tapering withdrawal.
Yeah, and in the learning module that you mentioned earlier, Dawn, Professor Chu Graham does say that patients should be warned of the potential risks of stopping antidepressants abruptly. And she outlines several different tapering approaches, which include proportional tapering, where the dose is reduced by a set percentage, for example, 25% of the previous dose until the antidepressant is withdrawn. Then there's hyperbolic tapering, which is where the steps by which the dose is reduced become smaller and smaller as the dose is lowered. So you would reduce the dose by 5 milligrams, then by 3 milligrams, etc. On a practical note, Professor Chu Graham says that sometimes liquid preparations of antidepressants can be considered when smaller doses are difficult to provide as tablets. However, she does say that these are expensive and local prescribing guidelines may not support their use.
Learning with other GPs at an in-person or a virtual event always gives you a bit of a buzz. And alongside e-learning, it's an important part of learning for appraisal. MIMS Learning offers plenty of opportunities for live learning, and you can find details on our events page, found through mimslearning.co.uk. Have a look today.
Okay, so we're talking about ensuring people are not left on antidepressants without regular reviews and how to go about withdrawing antidepressants. But depression can be a complex condition to manage, and sometimes people do not respond to antidepressants, or even when they do, they will have a recurrence of depression. In our clinical review of depression, Dr. Mario Di Ruena comments that about 60% of people who receive treatment for a depressive episode will experience a second episode within a 5-year period, with an average of 4 episodes over a lifetime. And of people who respond to treatment with antidepressants, only 1/3 will achieve complete remission with the first antidepressant agent. The other 2/3 of respondents retain some residual symptoms even after 4 treatment attempts. Among residual symptoms, the most common are insomnia, pain, fatigue, loss of pleasure or interest, and cognitive dysfunction. The least common are depressed mood, suicidal ideation, and psychomotor retardation.
Earlier, we spoke about the PHQ-9 questionnaire and how that considers the effect that depression is having on a person's life. And to add to this, Dr. Giroena comments that people with depression may have persistent and severe psychosocial and occupational impairments even after recovery from an acute episode. And he adds that these effects can have a wider economic impact. As well as episodes of depression leading to sick leave, they're also associated with an increased use of medical services. And of course, with depression, the major concern is that someone may harm themselves or end their lives. More than 700,000 people die by suicide every year, and suicide is the 4th leading cause of death in 15 to 29-year-olds. So for GPs and other healthcare professionals, a significant challenge is in identifying those at risk of self-harm or suicide and giving them the necessary support.
We do have a module, again by Professor Chu Graham, on exploring the risk of self-harm and suicide in primary care. She observes that young women have the highest risk of self-harm, but men, young and old, have the highest risk of suicide. While not everyone who self-harms or has suicidal ideation will have been diagnosed with clinical depression, there's obviously a clear link between these behaviours and depression. Of note, self-harm itself is a risk factor for suicide. According to Professor Chu Graham, the risk of suicide increases 50-fold in people who have had an episode of self-harm in the past year compared with those without such history. Other risk factors for self-harm or suicide to consider are specific occupations. Healthcare professionals are at increased risk of suicide, with anaesthetists at highest risk. Farmers are also at increased risk for suicide. Access to means, such as drugs, and geographic location, for example, living near a train station, is another factor.
A key issue with identifying the risk of self-harm and suicide is that people might not tell anyone, least of all their GP, how they're feeling. But if a person has presented to you with any mental health concern, then that represents an important opportunity to ask them if they've been experiencing thoughts of self-harm or suicide. Obviously, this has to be done sensitively and with extreme care, and Professor Chu Graham has set out some steps for sensitively assessing the risk of self-harm and suicide in her module. Now, these include establishing a rapport with the patient, assessing current or previous self-harm behaviours, assessing current thoughts, plans and intent, and considering how to ask questions about self-harm and suicide. She says your questions could be direct or normalising. For example, you could ask the person if they've been having thoughts of self-harm, or say something along the lines of, sometimes when people are feeling distressed, they think of harming themselves. Is this something that you've been thinking of?
Expanding on that, if someone does express thoughts about self-harm, or a GP thinks that a person is having thoughts about self-harm, Professor Chu Graham says to assess whether they have any protective factors in place. That is, think about what is stopping that person from harming themselves. GPs should also discuss and agree a management plan, including considering referral to crisis teams and offering proactive follow-up, such as booking a follow-up appointment.
Additionally, if a person who has self-harmed is being supported in primary care, NICE states that GPs should ensure that the person has regular appointments with their GP for review of self-harm thoughts and behaviour, regular review of medication, and is given information about available social care, voluntary and non-NHS sector support, and self-help resources. And we'll be listing some of these resources on both the module version of this podcast at mimslearning.co.uk and in the podcast notes, so do take a look. Of course, ongoing management of any coexisting mental health problems is important, including referral to mental health services as appropriate.
Okay, so what have we learnt this week? NICE states that depression severity exists along a continuum and is essentially composed of 3 elements: symptoms, duration of the disorder, and the impact on personal and social functioning. The severity of depression is therefore a consequence of the contribution of all of these elements. Importantly, antidepressants should not be prescribed for people with less severe forms of depression, and instead non-pharmacological therapies should be used. While antidepressant withdrawal symptom may occur less frequently than previously thought, it can still occur. Current advice is to avoid abrupt withdrawal and taper discontinuation instead. Several methods can be used for tapering, including proportional and hyperbolic. People with depression may have persistent and severe psychosocial and occupational impairments, even after recovery from an acute episode. These effects can have a wider economic impact. As well as episodes of depression leading to sick leave, they are also associated with increased use of medical services. Major concern with depression is somebody may harm themselves or end their lives. More than 700,000 people die by suicide every year, and suicide is the fourth leading cause of death in 15 to 29-year-olds. For GPs and other healthcare professionals, a major challenge is identifying those at risk of self-harm and or suicide and giving them the necessary support. The risk of self-harm and suicide should be assessed in anyone presenting with a mental health condition. Thank you for joining us today. Just to recap, we will be putting resources for anyone who is experiencing thoughts of self-harm or suicide in the podcast notes and on the module version of this podcast. Don't forget that you can claim CPD credits for listening to these podcasts, and there are plenty more available on the MIMS Learning website. We've been the MIMS Learning editorial team, and this episode was produced by Nav Powell. Look out for our next episode, where I will be speaking to Dr. Sunita Kochhar about cardiovascular disease in women.